Hello everyone, I'm Eunbee Cho, a resident at UTRGV Knapp Medical Center Internal Medicine Program. I want to discuss a case about a 62-year-old woman, ESRD patient on hemodialysis, who was diagnosed with a high output heart failure. I wanted to discuss about this case because I felt that compared to its significance in patient prognosis, we missed this diagnosis due to unfamiliarity and lack of investigation. This patient was a frequent flyer at Knapp Medical Center for hypotension requiring vasopressor after hemodialysis. She would sometimes come in for signs of acute decompensated heart failure as well. The most recent echocardiogram showed preserved ejection fraction at 70% EF and a questionable pulmonary hypertension with RVSP more than 77. So the plan was discussed to investigate further for possible high output heart failure. High output heart failure presents like a classic heart failure but has different etiology and pathophysiology. It is caused by a compensatory increase in cardiac output in the setting of either increased metabolic demand, in case of hyperthyroidism, or reduced systemic vascular resistance, like in this case, where you have acquired AV fistula or AV graft for hemodialysis. Unlike classic heart failure, high output heart failure patients tend to have increased cardiac output and less systemic vascular resistance. They would also have elevated PCWP, which coincides with the expected elevated left-sided cardiac filling pressure. Echocardiogram would be a good diagnostic tool to start with. When you see images of the echocardiogram in this patient, she had findings suggestive of high output heart failure with a preserved ejection fraction at 70% or more, dilated IVC at 2.83 centimeters, and enlargement in right ventricle and right atrium with the measurements 6.9 centimeter and 7 centimeters respectively. Left heart cath didn't show any obstructive coronary artery disease. Right heart cath was done for in-depth evaluation with direct measurements of cardiac output and various hemodynamic values. It was done with a special protocol to observe for Nicola-Doni-Brennan sign, which is a sign of a decrease in heart rate, increase in arterial blood pressure, and a decrease in cardiac output with a temporary occlusion of the graft or fistula. If you see Table 1, these are the measurements of the right heart cath. The values before and after the 30 seconds occlusion of AV graft, which was done manually by the skilled hemodialysis nurse. Although heart rate did not decrease as expected, MAP increased significantly, with a dramatic rise in systemic vascular resistance. Cardiac output was high at baseline, which is expected in high output heart failure patient, and the cardiac output decreased 17% with occlusion of the graft for 30 seconds. PCWP was elevated at 18, which was also expected. The plan to refer the patient for graft excision was discussed. However, at this point, we cannot follow up because the result after the excision is not yet available. This case was rather a complicated case where we suspected a combination of high output heart failure as well as pulmonary hypertension type 1 and type 2. This case highlights the significance of recognizing high output heart failure in ESRD patients with AV access, either fistula or graft, who might present with uncharacteristic heart failure symptoms like this patient. Timely identification and intervention are essential in these patient groups. So I wanted to report through this case report and highlight the significance of diagnosing this high output heart failure in possible candidates. Thanks for listening, and if you have any questions, please leave me an email as written in the right lower corner of this slide. Thank you.